I'm Angela Morton with Recovery's Community NWPA grant projects through Hemet Health Foundation. We are working on grant projects through the Rural Communities Opioid Response Program, and we bring you this video series called Recovery Is to talk about substance use or drug and alcohol recovery. And today I'm with Dr. Mandy Fauble, the Clinical Care Director, Director of Clinical Care Services at UPMC Western Behavioral Health at Safe Harbor, and with Dr. Claudia Chapa, who is the Medical Director of the Behavioral Health Unit at UPMC Northwest, who is part of our grant consortium doing this work to increase awareness of and access to substance use services. So thanks for being here with us today, Dr. Chapa. Could you tell us more, talk to us about co-occurring mental health and substance use disorders, or when they occur together or a person has both?
Sure. Thank you for inviting me, Angela and Mandy. It's really a topic that I enjoy a lot discussing, and it's very important for us to be able to talk about it with freedom and without judgment, so we can engage people in the appropriate treatment. One of the things that I do on a daily basis is treat people that have mental health problems and substance use problems. So we call them co-occurring substance use and mental health disorders. Usually half my patients, 40% of my patients may have a co-occurring substance use, drug or alcohol, which they're struggling with, and talking about them of how we can assess it, how we can address it and treat it. It's something that I do on a daily basis, trying to see where my patient is on recovery, if they are wanting to reach a goal, which is very personal, and me helping them achieve that goal. So that's my pretty much my goal with them, trying to see where they're at and then go from there.
Something that I'm wondering about is sometimes I hear about this thing called self-medication. So people will describe that sometimes when people have a mental health concern, they do this thing called self-medicating. Can you maybe talk to us a little bit about like what that looks like? You know, what does it really mean, and what happens when people self-medicate?
Sure. A lot of the times there are symptoms that might guide us as mental health providers to say maybe this person is struggling with anxiety, or maybe they're struggling with a mood disorder like bipolar disorder, schizophrenia, ADHD, you name it. And when there's not enough education or not knowledge about maybe these symptoms mean something, maybe these symptoms are part of like some characteristics that might lead us to do a diagnosis, people tend to do something to take care of the symptoms, which, for example, if you're struggling to sleep, if you're having insomnia, which is very common, people start to use melatonin, or maybe they are going to start drinking a glass of wine, and that can lead to drinking 2 glasses of wine because that's helping you pretty much get into a routine and pretty much sleep or even pass out due to the increased alcohol use in this example. So trying to address a symptom, self-medicating with either alcohol, opiates, or other substances is what we call self-medication. You are not in treatment. You're not in formal treatment with a mental health provider, psychologist, psychiatrist, MPs. And you are using what's on your hand pretty much that you think is helping you, but at the same time it's causing you more problems. So someone that might be struggling with anxiety, starting to drink alcohol and getting an alcohol use disorder might even increase the anxiety symptoms, because now their body is dependent on the alcohol, and if they want to stop it, withdrawal symptoms from alcohol occur. So that's one very typical example that I see a lot in my practice. So educating people of what's going on, what's happening, how one symptom can start to be a cluster of symptoms that can get really out of control, and then start having not only the anxiety disorder, but also a drug problem or alcohol problem.
This is very helpful because I think when then we think about how to intervene or how to help people, we have to start thinking bigger and thinking, well, maybe this person has a mental health concern that we need to address too, plus their substance use or drug and alcohol concern. And then for people that have experienced trauma, particularly, so things like child abuse or a sexual assault or combat, our brains, when they're impacted by trauma, also make it more likely that that substance use will be something that we struggle with. So there are all these things that, kind of go together. And I really appreciated when you said, if you're dealing with anxiety and then you try to stop using the substance, you have withdrawal, but your anxiety symptoms also are coming back. So, are there like special ways to help people that have a dual diagnosis or dual concerns?
Yes, of course. I mean, there are different ways that we can address a co-occurring substance use disorder and mental health disorder. First of all, doing a psychiatric interview, like getting to know what is happening in that person's specific situation that's causing whatever symptom or cluster of symptoms they're having, to be able to try to get a diagnosis. And I don't want to focus a lot on diagnosis as like the end result, because diagnosis might change, or diagnosis can point you to where should I start to think about how I'm going to be treating this person. It doesn't identify what I'm trying to say is, like, a diagnosis is not everything. A diagnosis helps us to make an assessment and a treatment plan. By any means is to stigmatize, which I know there's a lot of worries about having a diagnosis on the chart, because then what will happen to me in the future? And that being afraid of pretty much coming out, pretty much saying, this is happening to me, can have a lot of implications on the long run, because then we are not going to be able to treat the primary psychiatric diagnosis, and the substance use disorder can be brewing and can be complicating the main issue. And I'm glad that you brought to the conversation, Mandy, trauma, history of sexual abuse, history of neglect, kids not being taken care of their parents because parents are struggling with alcohol use, drug use, and these kids start to be pretty much be raised by themselves in the system, and this creates a whole lot of difficulties, which, if you don't address it as a kid, it gets worse as people age. And definitely there are medications. I'm not going to talk specifics about antidepressants, antipsychotics, because it's personalized. For treatment for alcohol use disorder, we have very good medication that can decrease cravings and can help people get into their goal. And the goal not always is sobriety. The goal might be, instead of drinking 6 beers every night, I'm going to drink 3 beers, and we'll take it from there. And working with them pretty much on a bi-monthly basis to see where they're at, how we can help improve their mental health, and if they are okay, if they want to change, even decrease more the alcohol use, and they agree with medications, we can also support them with that. So right now, when we talk about treatment for substance use disorder, is not sobriety per se. That a harm reduction is what our goal is. Where you're at, what do you want to achieve? How can I help you to cause the least amount of damage? And educating them, and of course, coming from a place of compassion and empathy without judgment is what I think helps people be really open in talking about their substance use and mental health problems. If you feel judged, you're not going to be getting anywhere.
Who wants to share with someone who's judging? And what I was going to say is I hear that in you keep saying, find out where the person's at. Medication is individualized. The diagnosis isn't everything. So I hope that anyone who's listening, who's been kind of on the fence about whether or not they should get into treatment or encourage a loved one to, is just to hear that, that there are providers and healthcare professionals out there that want to really provide people that space to kind of work through whatever recovery means for them and help them just, move towards their goals without pushing them or rushing them or judging them. And you brought up the whole concept of family and how, when we address our mental health and substance use needs as adults, we do a lot to protect children, and that without that protection, sometimes they then have risks moving into the future for mental health or substance use concerns. So we have the ability really to pay it forward, if we can take the steps to get connected to care. So I'm just so glad that you brought that up.
Thank you. And I mean, for example, therapy is not for everyone, even though we recommend it and it's something that is important as an extra support. Sometimes symptomatology is so acute that maybe that person first needs to address all the symptoms that they're having to be able to regulate themselves, to be able to talk about it. And everyone is on a very different recovery level. So that's why working with them to pretty much to help them achieve their goals is my main goal for on as an end game. Be supportive, and also collaborating with other specialties, because I know that there are not a lot of psychiatrists in the rural communities. There are not a lot of psych NP. So it's very limited the way that we can, that of course I would like all my patients to see a psychiatrist, psych NP, if there's no psychiatry there, so they can help them continuing their recovery process. But the reality is that there's not a lot of that. So collaboration is something that we have to continue working. So we can, even like a phone call, like, hey, I'm struggling with this person's symptoms. What do you think? That brainstorming of ideas can help the community.
Well, I really appreciate all the perspective on how the two different kinds of disorders come together. And maybe can you share, I think of how many people I've worked with, Mandy, all of us have worked with over the years, who they maybe know that they're struggling with both. And is it just a matter of let's reduce that stigma by getting more comfortable saying, I think I have depression, or I get really nervous anytime I leave my house, and maybe they don't know that that's anxiety, but being comfortable talking to your doctor, as you said, a nurse practitioner, anybody that maybe could help point a person in the right direction. So if somebody suspects they have some mental health concerns and they don't even know what those are, to be able to say, I know that I'm drinking a lot, or I know that I'm using pills that I shouldn't be taking that, weren't prescribed for me, or I'm smoking marijuana every day and I can't sleep if I don't, or I can't eat if I don't, whatever the substance is. Maybe people don't know which is the bigger issue at the time. Is it the mental health and then the self-medicating, or is it the dependency on the substances that are contributing to those mental health symptoms being worse? So is it really just about, would you hope that patients or anybody would just talk to you if they came onto the unit or wanted to talk to a nurse or doctor? Do you hope that they would just say, here's what's happening? And how would you encourage people to do that?
All right, so definitely, if someone comes to me like openly, that will be like the best case scenario. It will make my assessment much easier. But I know because of the stigma that we're talking about, people are hesitant, and I think that the way that we talk about our patients, the way that we the wording that we use to express ourselves has an impact. So if I were a person that I'm judging that because I have some countertransference towards a patient population, I talk bad as a physician, that's a big no. Ethically, it's not for me to judge. I'm here to help. And sometimes we might not without wanting, but it's something that as repetition and socially, we might say a word that is not an appropriate word, and people might feel very, very judged and threatened, even if we don't have no idea what's going on in their lives. So that's something that I've learned over the years. Like, you don't know who's in front of you and what they're struggling with. So it's better for you to keep your own opinion and listen. And sometimes just by listening and don't giving opinions, you're going to get a lot of information. So we have to be sensitive towards with whom we are working with. And just by changing the words, people will see that you come from a place where you want to help, that you're not there to judge. And that way is how people start to reach out, because they don't feel that push that, I mean, if I talk about this topic, all of the people that I'm working with, everyone has an opinion, and usually the opinion is pretty negative and judgmental and pejorative. So why would I talk about this? So starting like from us, how do we address, how do we word our thoughts and feelings? I think it's one of the best ways that I think that you can pretty much bring people to talk to you, because it's not always that easy. Sometimes people come for depression and they have no idea that they have an alcohol use disorder or a cannabis use disorder, an opioid use disorder. And then when you start to talk about them and they start to hear themselves saying all of this symptomatology and how one thing is connected with the other, that's when the aha moment comes from within. And that's when you can make people make changes, because it's coming from within. You are not pushing for them to change. So yeah, that's why like just talking to them, listening to them, and keeping your opinions until you are asked, that's a good way to start.
Really just the courage that you said, like to be brave and to talk about that. And sometimes people have lived in situations for so long that they don't know that something traumatic that happened is even traumatic, because they've been living in that frame of reference. So I think that unless people come out and say, I keep thinking about this thing all the time, and then you realize that maybe that thing that happened was really traumatic and is contributing to mental health or substance use. So really it comes back to, if in a perfect world, if we all could speak with compassion and understanding of substance use concerns and mental health concerns, then we would use compassionate language where more and more people could be brave, and it wouldn't even require courage to talk about it. So hopefully, if anybody's listening who needs help, I'll use that opportunity, and then we can wrap up, but I'll use the opportunity to say that if someone's listening and knows someone who is struggling, or if you're struggling yourself, there is help available. Treatment is available and it works. It's available regardless of your ability to pay for it, because often if you don't have health insurance, the single county authorities for substance use can often cover the services. Most insurances cover services for behavioral health and substance use. So look on the back of your card, call your local county and just say, I'm looking for drug and alcohol services or substance use services. They can do a brief screening that might just be a conversation, and you can stop there, or you could have an assessment to get into treatment. You can also call the National Substance Abuse and Mental Health Services Administration, SAMHSA. You can call 1-800-662-HELP from anywhere in the country and share where you are, and they will be able to get you connected to mental health and substance use services that way too. So I always just like to weave that in because we get in these conversations and we're all really passionate about it, and we want to promote awareness and reduce stigma, but we also want to make sure that we're always sharing that there are resources available for people to get help, and treatment really does work.
Yes, and you're not alone. There's always someone there that wants to help you.
Dr. Chapa, as you were talking, I was thinking how important it is for healthcare providers to adopt the stance that you've taken, but everything you said, it applies to all of us. The language of countertransference, which I always think is like, it just means that you haven't dealt with your own feelings and your own emotions, and it's kind of coming out on another person. Everyone can relate to that in their personal lives. And, when I think about how in our culture, it's like 1 in 10 people have had an alcohol use concern, let alone, other types of substances. There are so many people around us who are in recovery. There's really like every reason to be hopeful, but we are not hearing those recovery stories because there's so much stigma. It's not just all the negative stuff that gets kept in because of stigma. It's also that we are denying ourselves the ability to have hope because we're not having real conversations about how, people get better. So I think, I hope everyone heard that of like, I can do that. I can show up as a kind and caring and non-judgmental person, but it may also mean for some people getting support to kind of deal with whatever they've been through. I'm positive that part of what holds people back in their compassion with individuals with substance use disorders, maybe because they've been hurt. Maybe they had a really difficult experience in their own family, or maybe they've struggled. And so it can be harder to have those conversations. But just like there's help out there for people that have substance use disorder, there's help for people who have been kind of hurt by its effects, and if we all lean into this, we will have every reason to be hopeful. So thank you for such a universal message.
You're welcome. Thank you for the invitation.
Thanks for being here with us today. We really appreciate all the valuable information. Thank you, Mandy. And thank you for joining us for Recovery Is.